then move on to the education bit of it, and how quality control could be applied in the human resource preparation for management of breast cancer. And for that I invite Dr. Gabrielle Kane, who is the Associate Professor, Department of Radiation Oncology, University of Washington, Seattle.
Good morning. Thank you very much indeed for inviting me. Thank you, Ben. Ben and I have discussed training, education, and then suddenly evaluation popped into it when Winnie asked me for some advice on a training program, on advice on designing the curriculum. And I said, well, look, before you go on any further, what's this about? What are you trying to get out of this? And what are your measurables? And that started a very long and fruitful discussion and friendship over the last little while. So thank you for inviting me here. And I'd also like to acknowledge Carol Fisher and the amazing organization in this meeting. As you can see, I'm also part of the Department of Medical Education at the University of Washington, and my main role there is in developing an academic CME program. And so hello from Seattle. The key points that I'm going to make today, I hope, are that, number one, education is the prime way to translate knowledge and thus implement change in practice. Educational outcomes are healthcare outcomes, and the design of outcomes is absolutely integral to curriculum design. My apologies in advance, but I've decided that I'm going to actually use curriculum design as the framework for this talk. And what we've got to get is we've got to get measurable but context-specific indicators of improvement identified. And I'm certainly not going to talk about psychometrics here. You would all be asleep within 2 minutes, and then I would probably be snoring within 5 minutes if we did so. It's also irrelevant, in fact, unless one has dealing with actual hard data to start off with. And as you'll see, so much of the stuff in education, I'm sorry, is going to be the warm and fuzzies and softer outcomes. There's no way around that. So what I hope is what we're going to achieve is identification of appropriate outcomes essential to research, because what works in one country actually does work in another country if you use these basic principles. It's just that they have to be adapted for the different circumstances. But unless we have that information, we cannot do any research and we can't advance. So, why do you need these tools? Well, you've got to get evidence, as I just mentioned. You've got to be able to determine the effectiveness of this intervention and find out whether it worked. And most of all, as Peggy Porter said this morning, no evidence, no research. Education and implementation is mostly about shifts and changes. And it's also certainly about applied knowledge. We're not talking about the medical education interventions that happen when finally a medical student takes a qualifying examination and that this is graded and all the math of psychometrics is done to apply for it. Instead, what we're looking at is Miller's knowledge pyramid. When you know something, you know how to do it, and then higher up this pyramid, you're able to show how you do it, and you actually do it in practice. This pyramid has been further adapted by Don Moore to give for the world of CPD and CME evaluations. And for level 1, we've got attendance at CME or CPD activities, bums on seats. So we can count you and we can get a metric there. Satisfaction, that's the happiness index. Was it nice? And that often refers to the room temperature and the coffee. Did you learn anything? We're getting a little bit more hardcore here. And you can do pre-test, post-test measurements, for example, and see that there has been a gain of knowledge. You can actually then go back 6 months later and measure the rate of decay of that knowledge. But then we come to performance. Can you actually do what it is that you learnt? And that then has a further 5th level. If you perform well, does this result in a change in healthcare outcomes? And this is where we want to go. This is the whole point of doing any sort of CME, professional development, implementation. Unless you actually end up improving healthcare outcomes, there's absolutely no point in doing it. Oh, whoops. What have I done here? So when it comes to identifying the measurables, there's been lots of work done on this, but it's absolutely different for every situation, and that's why you can't just identify a metric, unless you're measuring the knowledge of final year medical students. And even that is seriously questioned these days. So when you look at clinical outcomes, lots of good work done on interventions, educational interventions, where you can measure some sort of hardcore clinical outcome, a reading such as blood pressure, hemoglobin, H1A in diabetes care, and also, of course, changes in morbidity and mortality, examples that have been used consistently and appropriately over the last few days. But they don't have to be clinical outcomes, because through education you can actually make both process and organizational change. You can change, as we've heard again repeatedly over the last few days, you can change access to care. And then you can actually measure the number of women undergoing breast screening, for example. You can change the type of care as well. The number of women receiving adjuvant tamoxifen is another example. And you can make significant changes in the quality of care. And the example that I've got here is improved clinical efficiency. You can all think of more and more examples, and they have been well illustrated, as I said, over the last few days. So the measurables actually all depend on both the purpose and the objectives of the intervention. I always use this one. Are you trying to cure cancer overnight? Well, yes, at the Fred Hutch, we are. But in lots and lots of baby steps, we've got to get there. And one of the ways of getting there, perhaps, is improving access to care. But we need baseline measurements all of the time. We've got to identify these gaps. The gap analysis, just as in implementation science, is just as important in education. You've also got to, of course, recognize the multiple confounders. When Peggy put up the slide of all of the different inputs that there are in implementation science, and education is only one of those. You surely don't expect that one CME is going to result in cure of breast cancer. But if we improve some of the steps in that, at the same time as all of those other engineering, social science, and IT changes are made, maybe we will. I'm just going to illustrate one of the standard approaches to CME planning that one encounters an awful lot. Let's put on a CME in breast cancer. We can talk about breast cancer. The docs in some remote place need to know about this. Sort of a top-down approach. Who will we ask to cover the cost? 2 days, 4 plenaries, 60 10-minute abstracts and a panel, easy, done. Okay, I think that was just fine. Didn't we do well? It's a little bit missing there, because what would happened here is we've gone from the why, the what and the why of the CME through to the how of the CME and the event, but then just letting everybody go home and forgetting about it. I suggest that we've got to complete that loop with proper curriculum design and ask the question, did that work? So evaluation, completing this loop, the loop that I put up, and it also informs what happens with the next ones. And most people get that if you give feedback on an educational intervention, that the next program in this will be improved. But you also have to say, well, what did we accomplish during this? And find out about the income. In other words, finding out what sort of outcome you got from this, so that then you can use that as a baseline to further modify your program in the future. And this is an important thing to realize, is that any sort of educational intervention is never just a solo one, it's always part of a larger program.